So let's look at the anatomy of Van. Look at brain maps. In general, brains of mammals and spinal cord are arranged in the same way, and we'll see this in that all sensory is towards the back, hence the dorsal column of the spine is where the sensory is, and the motor is towards the front. Well, the brain is like that as well. So the frontal lobe and has the premotor area, and then the motor strip is in front of the sensory. We know that vision is in the back of the brain. We know that hearing is in the back on the sides of the temporal. So that is the basic configuration of the brain. We know that patients that have a major stroke on the right side have neglect. Patients that have a left-sided stroke, they usually have aphasia because that's where the language is. Another thing that's important about Van, gaze preference, we put this under neglect. I know it's a pseudo neglect, but it's also a way to see if there is a large vessel occlusion. And then we also go over the anatomy of why motor testing is central to everything that we do. So right here, so here is the motor strip. It's right in the middle of the brain. So think about it this way. There's an artery here that goes to the frontal gaze center. There's an artery here that goes to Broca's, or an expressive aphasia, inability to talk. The one in the middle goes to motor, then goes to neglect, then hearing and understanding. This is the inability to hear or understand, and then vision back here. And you know, if there's one big artery that supplies all this, what's in the middle? The motor. So vision's back here, aphasia, ability to make words right here, and the ability to understand are right here. Neglect is both the neglect classic sense, but also in gaze preference. So this is the homunculus. So this is the motor and sensory cortex. And you can see the leg is very small and very distant from where the artery comes up. The artery comes up around here, right? That's why we chose arm, because it's in between the face and in between the leg. And sometimes if someone only has a facial weakness, do you really want to take the 5 to 10% risk of a brain bleed with endovascular treatment? Only if someone has arm and leg involvement do you want to take that risk. Of course, there are exceptions, including a severe aphasia. But, you know, generally you want some motor weakness. This is just another brain map showing us the same thing. The motor cortex, the primary sensory cortex. Here it says Wernicke's area interprets a spoken and written language. Again, interpretation, input is towards the back, output and motor and thinking is towards the front. Broca's area, this affects fluent speech. All right, this is another way to look at it. All these arteries, you see that? If it's one big artery, motor cortex is in the middle. So let's talk briefly about large vessel stroke versus small vessel stroke. So location of vessel is important, right? So small vessel occlusions are these tiny little arteries right here. So either from high blood pressure, diabetes, or aging, or small little distal clots, okay? These are small vessel occlusions, and the ones in small penetrating arteries are usually what's called lacunars, and these are distal small vessel occlusions. So how do you know these symptoms? How do you know these? From the symptoms. They usually don't have many cortical symptoms or just one cortical symptom, right? So one artery, so you'll have one cortical symptom. As soon as you have two cortical symptoms, then you know the clot is here, proximally, which is what Van does. It looks for, look, there's one division here, looks for clots here, here, in the carotid, terminus ICA, the middle cerebral artery, or even the basilar, right? Because then you're getting multiple branches. How do you know? You have more than one cortical symptom. What are cortical symptoms? Loss of vision, you can't see anything towards one side. Aphasia, inability to understand speech or to produce speech. Or neglect, your eyes are forced over and you're neglecting part of the world, okay? So this is a case example. You see this patient right here, the right side of the brain, sorry, the left side of the brain controls the right side. See, he has a right facial droop, you see right here. This, he's able to smile here, but not on this side. So what is it? He actually has no flow over here. So this is the artery, which goes underneath, right? Then there should be another artery here, the anterior cerebral towards the front and the middle, all right? And this, same thing, we just talked about this, right? This is where the clot is, all right? So small vessel, lacunar versus large artery. Lacunar usually is pure motor or pure sensory. So they don't have cortical symptoms. They don't have an aphasia. They don't have visual field cut, meaning they can't see anything towards the left or anything towards the right. They don't have neglect, where their gaze is forced over or they're ignoring one side of the world. Large artery usually has cortical symptoms, okay? This is simplified, but for practical purposes, it is a good heuristic. There are subcortical aphasias. You can get visual field cuts from some small artery strokes, but this is a heuristic to identifying these massive strokes right away. So why can you get all this weakness, face, arm, leg, and still not have a large artery stroke? Well, if you look at it, our spinal cord is the size of a what? Of a quarter or a nickel, right? How could that be when our brain is so big? And here it says that the leg and arm and face take up half the brain like this on the side. What happens is all these come together into a small little bundle, right? It's called the internal capsule. Look how small that is. If you have a tiny stroke here, you can take out your face, arm, and leg. And this is shown right here as well. And here it comes down, all this big capsule, so all this half of the brain comes down to a small little thing and goes all the way across the brainstem, crosses in the pons, and goes into your spinal cord. So you can have any of these lacunar in the pons, midbrain, thalamus, internal capsule. All these can give you face, arm, and leg complete paralysis with a very small stroke. Again, small artery strokes, how do you tell? They're usually pure motor or pure sensory with no cortical symptoms. Now let's review the functional anatomy of the brain and compare VAN versus other large artery screening tools, right? Because now I've kind of gave you the basics of what the difference between large artery and small vessel stroke is. So now we know, right? Motor weakness is used in almost all of the large vessel screening tools due to its central location, as well as its link to functional independence on the modified Rankin scale. This modified Rankin scale was used for all 5 endovascular stroke trials. So technically, having this type of weakness can predict, in a sense, if taking the clot out and giving you the ability to move again will make a difference in your functional outcome, right? So let's take a look. The first one is RACE, Rapid Assessment of Occlusion of Emergent Large Vessel Artery, right? And so this RACE score tests all of these: face, arm, leg, neglect, and inability to understand or talk, basically aphasia, and vision and gaze preference. But it's a relatively long exam. Look at this. You test face, you have to score 0, 1, or 2. You test arm, then you score 0, 1, or 2. You test leg, then you score 0, 1, or 2. You look at their head and their gaze deviation. You test aphasia. You have them asked to do both tests correctly, perform one test, 1 or 2. And then you have to tell, okay, is it the right side is weak or is it the left side is weak? You see how this scoring system, someone can probably say 1, someone can say 2, in all of these. And so the inter-observer reliability of this has to be questioned. In addition to this, now I went over pure lacunar syndromes, right? So you can have here, it says above 5, right? You can have a 1 here, 2, 2. It's a 5. This would tell you it's a large artery stroke, but guess what? 30, 40% of the time it's not. It's a lacunar stroke. Only face, arm, and leg, right? So these are some of the things that we have to be concerned about. Legs, it's a similar one, but they don't test face or arm, and they neglect. Same thing, 0, 1, 2, 3, 4, 0, 1, 2, 3, 4, right? And they only test the leg, which to me doesn't make sense. It's the furthest things out, right? You can miss lots of small NIH, but large vessel occlusions, which can go on in the next 24 hours to become larger. So the use of leg only without the face and arm, it's so distal, you know, not always the best, but again, you have to calculate numbers, right? Calculate, right? And and again, it has a pretty good ability, you know, its sensitivity 69%, positive predictive value about 60, which is better than the positive predictive value of race, which was only 42%. All right. So the LA motor scale, well, neglects all cortical symptoms. It's just a motor scale, right? We talked about why this is not very smart due to all the lacunar strokes that present with pure motor symptoms. Again, and even this simple scale has you actually count all the numbers up. Oh yeah, if it's greater than that, then it has an 89% sensitivity and 89% specificity for large artery clot. But you have to score a lot, and on top of this, they don't tell you what the positive predictive value is. Hemiparesis, same problems. Cincinnati Pre-Hospital Stroke Severity Scale, similar. They neglect, and don't test vision, you know. But same with the other ones. Scoring as well. And only 40% specific. 3 items stroke scale, similar, neglects lots of the aphasia, the neglect, the vision. Again, still makes you calculate scores. So VAN. So VAN tests all this, but you never have to calculate a score. And guess what? Just like all the pure motor ones, we put motor in the middle. It's the first thing we do. We have you put up the arm for 10 seconds. If you have 0 weakness, you're done. You're done with the exam within 15 seconds. You don't have to do the entire exam like all of these and calculate numbers, right? But then we don't neglect anything. We don't neglect any cortical symptoms, right? So let's compare race, legs, LAM, CPSS, and VAN, right? Test cortical symptoms, yes we do. These other ones do as well, right? This is a pure motor one, so it doesn't. No need to calculate score, that's us. Everyone else has to. No need to test severity, that's only us. Everyone else has to. Does not test one MCA branch multiple times. They all do, because they test face and arm, or face, arm, and leg, right? Right? Has online forms. We do. You can download our forms. Has website and teaching videos. None for the others. So why VAN? We just went over this. No calculation of numerical score. Uses motor weakness as central point to triage. Uses cortical symptoms without severity and scoring, which actually allows for better inter-observer reliability. VAN teaches what cortical symptoms are. I just taught you over this last lecture. The mnemonic helps. VAN, oh yeah, vision, aphasia, neglect. Dr. Taleb went over this, right? And does not overtest one division of the MCA by testing face and arm and leg, or face, arm, leg, and hand, right? So for us, we've had 6 patients with NIHO scales of greater than 10, all turned out to be lacunar, all VAN negative, because they were pure motor and sensory with no cortical symptoms. And so that's why it's powerful. It's in a sense the simplest and the best, all in one. Conducting VAN properly. Weakness is the essential question. Why? It's the middle branch of the MCA. It affects disability scales and outcomes for independence. It warrants the risk of endovascular treatment because there is permanent motor weakness. So that's the first thing we do. We have you put up both arms and hold them up for 10 seconds with palms up. And you can refer to our video on how to do this, right? But we have you mark how severe it is, but you don't score it. If you have any weakness at all, then you go on to do the vision, aphasia, and neglect. If patient shows no weakness, patient is VAN negative. We put this for our ED physicians and because people around the country and the world miss basilar arteries. Someone is confused or comatose with dizziness and focal findings. These are patients you should consider basilar artery thrombus and do a CTA. But I'm talking about awake patients that show no weakness and they're VAN negative, right? So that's the first thing. If they have no weakness, you're done. If they have weakness, then you test the visual fields. We test the 4 quadrants, okay? And then we have you have them look toward the right, towards the left, and just see if their eyes are uneven to pick up a double vision. I picked up 2 top of the basilar strokes with a minor weakness and basically a double vision. Their eyes were disconjugate from the VAN exam. Okay. Then you test for aphasia. We all know how to do this. I never count slurring of words because that can happen from a pure motor weakness. If somebody is talking like this, but he's able to talk, guess what? He's either drunk or has a pure motor weakness, okay? I'm talking to you, I'm understanding you. So the first thing we do, repeat 2 objects. I usually use my watch and a pen. Then I have you follow 2 commands. Close your eyes and make a fist. And then I have you repeat something, okay? Today is a sunny day. If you can't do any of these, then I mark which one it is and say you're positive for aphasia. Anytime you have a weakness plus aphasia or weakness plus vision loss, you're automatically VAN positive. You don't have to be vision positive, aphasia positive, and negative, and neglect positive. Anything with motor weakness, you're automatically VAN positive. So if you have motor weakness plus vision loss, you're VAN positive. Motor weakness plus aphasia, you're VAN positive. Motor weakness plus neglect, you're VAN positive. Neglect, so you just look at the person, do they have forced gaze to one side or they have the inability to go past midline? So if you're standing on the left, can they not go look past the midline? Or if they're standing on the right, they can't look towards you, okay? And then you have to touch the right hand, then the left hand, then both hands at the same time with their eyes closed. If they tell you when you touch both hands, they're only feeling the right or only feeling the left, that means they're neglecting you touching both sides. And that's the entire VAN exam. So what's next? Well, let's look at some neurointerventional results. This is someone, and you see how fast we're becoming. 148. You see there's no blood flow to half the brain here. There's a big clot right here. 148 is when we started. You have bypass flow at 59. So within 48 to 59, 11 minutes. You have complete recanalization by 06. 18 minutes, complete recanalization. Look at this. There was no arteries here before. And this was January 6th. January 5th, same thing, right? You see no flow on this side. 27 after. 38. Again, within 11 minutes, we have bypass flow for stent retriever. By 45, we're done. 27 to 45. 18 minutes again. January 5th. January 6th was the other one. Just December 30th was the one before that, right? 1106. This is why you should use a biplane machine, because if you had looked at it straight ahead, you might not have caught this, right? But then if you look over here, half hour. Most cases are less than a half hour. December 20th. Again, why it's so important to have a biplane, so you can see this. Complete recanalization. Here we go. Despite the fact that she has intracranial athro everywhere, stent retrievers still work very nice. And again, these are non-randomized cases. You can see this is just within 1 month. That is it. Please feel free to contact us about VAN, vision aphasia neglect, large artery stroke, large vessel occlusion screening. We appreciate you coming to our site, taking the time to learn why we're doing this exam and how it makes a big difference in patients' outcomes, and seeing how effective we can pull out clots now. We're at 95% TICI-2B or TICI-3, which is complete recanalization, or greater than 50% recanalization to brain tissue. And the outcomes of stroke are becoming better and better, especially for these massive strokes. Thank you so much, and please feel free to contact us with any questions or concerns.